Afternoon, everyone. I welcome you all for today's webinar, Updates in HCC. I would like to thank Dr. Anand B. Kulkarni for organizing this conference today. He is Senior Consultant Hepatologist at AIG Hospital, Hyderabad. With immense pleasure, I would like to invite our first speaker, Dr. Mithun Sharma, for giving the talk on epidemiology and pathogenesis in HCC.
So is it coming in full screen?
Yes, sir.
Yeah. So today, good evening, good afternoon, everyone. So today the outline of the discussion is basically on the epidemiology and the role of diagnosis and how do we try to detect these cancers early is our main aim of today's discussion in the next 15 minutes or so. So when you talk about epidemiology of HCC, we can divide it into regions of high incidence, of moderately high incidence, intermediate incidence, and low incidence. We call it as a high incidence when it is more than 20 patients per lakh of population. This includes countries like Japan, China, and the Eastern Africa. The moderately high are between a range of 11 to 20 per lakh. Low incidence are less than 5. And if it is between 5 to 10, we call it as a zone of intermediate existence. Now, the question here is that is surveillance justified? Surveillance means trying to detect the disease before it has come. So how do we justify surveillance? There are various criteria which people have put forward. Some people believe that it is considered to be an effective surveillance if it can provide an increase in longevity by around 100 days, or if you can do it at a cost of less than 50,000 USD per year of life gained. The European Association of Study of Liver Disease has defined it as if the incidence is more than 1.5% per year of any disease, it warrants surveillance irrespective of the cause. Now, this brings to the bigger question, does surveillance program helps for detection of HCC? The answer here is that these are the very initial trials. So this was a population-based randomized control trial between surveillance ultrasound and alpha-fetoprotein measurement 6 hourly versus no surveillance. This was a study of around 18,000 patients aged between 35 to 59 years in urban Shanghai who had history of hepatitis B, and it was regardless of the presence of cirrhosis. If you see in the study, despite a suboptimal adherence, that is the adherence to the surveillance program was only 55%, yet it was seen that surveillance could decrease the mortality by 37%. There are other studies which tried to use no ultrasound, but only alpha-fetoprotein for HCC surveillance. Again, a study from China, where they included hepatitis B positive, high-risk male patient. However, using only alpha-fetoprotein did not show any benefit. This was possibly because alpha-fetoprotein can be normal in around 30% of liver cells cancers. But there are many other studies which have showed that regular ultrasound can also help in detection of HCC. Now, this is a summary of slide of how the different societies recommend who to undergo surveillance. If we see the EASL, the ASLD, and APASL all agree on the fact that patients of hepatitis B, C, NASH, and alcohol-related cirrhosis who are in child A and child B needs to be under surveillance. However, the EASL and the ASLD believes that the surveillance is beneficial or cost-effective only if the patient is awaiting transplant. This is because they feel that if it's a child C patient, if we go by the treatment guidelines of HCC, it will be anyway a best supportive care. So we would possibly not be adding lives to these patients. On the other hand, APASL of the consensus that we should still be surveilling these patients because sometimes the decompensation that happens and the reason the patient has gone to child C status could be because of the malignancy itself. There has been debates on whether the non-cirrhotic patients needs to be screened, but patients of Hep B are definitely needs to be screened, particularly if they are Asian males greater than 40 years or a female greater than 50 years. We can use different criteria like the Page B score, which includes platelet count, age, gender. And if a score is less than 9, we can call it as a low risk of ACC, and these are the patients whom we may not screen. But if it is having a score of greater than 18, it means this is a high risk for ACC of 17% at 5 years. So these are the patients who needs to be screened. So the controversial group in our real life practice, we would still screen these patients of Hep B, non-cirrhotic, and even patients of non-alcoholic fatty liver disease, as it is likely going in the next 10 to 15 years, going to replace all other causes as one of the major cause of ACC. We need to identify high-risk model scores to identify these patients. The ASLD guidelines feels that if there are additional risk factors like smoking, alcohol, which increases the risk by 9 times, then these are the patients who would possibly need to be screened, even if they are having chronic hepatitis B without cirrhosis. So how do we screen these patients? The EASL guideline believes it should be a 6-monthly ultrasound, though this has changed recently with the new guideline coming up. The ASLD feels it is ultrasound with or without alpha-fetoprotein. The APASAL says it's ultrasound and AFP. In our clinical practice, we use ultrasound as well as AFP, both every 6 monthly to screen these patients. So when we screen these patients with ultrasound, the problem is that 20% of the ultrasound that are done are classified as inadequate. So we call ultrasound screening as negative if no focal abnormalities have been identified, or there are some abnormalities which are definitely benign like cyst. Any lesion which is greater than 1 centimeter is considered to be positive screening and needs further test. Lesions below 10 millimeter, which are definitely not looking benign, are non-diagnostic. A meta-analysis of 17 studies have shown that the clinical pool sensitivity is around 94%, and the specificity is 94% again for detection of tumors. But if we bring it down to early HCC, it comes down to only 63%. There is no debate on the fact that ultrasound comes with easier benefits like non-invasiveness, good acceptance, but there are a lot of intra-observer variations. Many of the isoechoic lesions are missed, and of course, the quality of the machine depends. Alpha-fetoprotein as a marker, I would rather give a comment that it is considered more as a diagnostic tool rather than a surveillance tool, because we know that the alpha-fetoprotein levels can be fluctuating in the natural history of cirrhosis of liver or in patients with Hep B and Hep C. And also, we know that there will be a percentage of patients who will not present with a high AFP. Also, there is a debate on the cutoff of alpha-fetoprotein. If we take a cutoff of 20, the sensitivity is 60% and the specificity is 90%. But if we take a higher cutoff like 200, you might be able to increase the specificity, but the sensitivity falls to 22%. If you see this chart here, at different levels of alpha-fetoprotein, the sensitivity falls dramatically, and higher the level, the specificity increases. So is it possible to combine alpha-fetoprotein and ultrasound? Yes, it can identify more cases, but it leads to a 7.5% false positive rate, thereby leading to an increase in cost because these patients will be unnecessarily doing MRIs and CTs. So alpha-fetoprotein alone is still considered as an inadequate screening tool for diagnosis of ACC. Whether we can combine other markers like alpha-fetoprotein combined with the L3 fraction along with the age and gender, which is the Gallard score. This is the original data, which had a sensitivity of 86%. Then it comes down to 73% for early ACC. The latest data shows the pool sensitivity is around 80% with the Gallard model. Now, many people, and in our clinical practice, we do have a bias towards doing a CT or a cross-sectional imaging at the first diagnosis of a patient with liver cirrhosis, though none of the guidelines mention. So there's no data actually to support the use of a CT or an MRI for surveillance, excepting the patients who are, say, morbidly obese, who are having a chest deformity where the ultrasound is not able to pick up, or if this is a patient on a transplant waiting list, where we are doing a CT or an MRI for a volumetric assessment or for an MRPDFF assessment. But MRI definitely has a lower false positives test when compared to ultrasound in a study, but again, this needs validation in longer cohort. The next big question is, how frequently do we surveillance these patients? So it depends on the mean doubling time of HCC, which is around 6 months. So most guideline believes 6 months is the ideal time, but the Japanese are very aggressive and they feel that the screening should be done at 3 months interval. Randomized studies have compared 3 versus 6 months. They failed to find any difference. But yes, if you screen between 6 and 1 year, there is definitely a difference. So 6 months is what is acceptable. If there is a lesion, we need to have an early recall policy. Recall policies are important. Nodules less than 1 centimeter, the ASLD believes that you have a follow-up at 3 months. The EASL believe we follow them up every 4 months for a year, and then 6 monthly. And any lesion which is greater than 1 centimeter will warrant further investigations by some modality of cross-sectional imaging, including a biopsy if at all required. So we might come to a point of time where one size may not fit all. So we may have a patient with cirrhosis of liver Hep B, and then we see the risk stratification model. We use a risk calculator, and then we classify them as high risk, medium risk, low risk. And then we have a screening strategy, 1 for low risk patient, a screening strategy 2 or 3 for the medium and high risk patients. So we might just think that for the high risk patient, let us do something like an abbreviated MRI. For a medium risk, we use ultrasound and biomarkers. For very low risk, we might use some biomarker panels. But these are prediction models, which can come very much useful, provided we use it and provided our ultrasounds are done with a dedication to find out small lesions. There are novel biomarkers for screening, like the Fujifilm Waco panel, the Gallard. Also, there are some liquid biopsies, but none of them has been able to pick up very early liver cancers. So their role is more in identifying tumor cells in the circulation rather than to detect a very early cancer. Abbreviated MRI is something which is novel, which takes T1 contrast phases images. Its sensitivity and specificity has been found in studies to be similar to triphasic MRI. It is safe, non-invasive, and cost-effective and time-saving for the radiology department. But again, this is something which has to be interpreted properly. So as we try to find more and more cases, it will definitely increase the cost as well as harm to the patients, in the sense that these patients become very tense the moment you say that there is a nodule in the liver which can be a cancer. With this, I would end the talk on surveillance today and hand it over to the other panelists to carry it forward. We'll be happy to answer if there are any questions. Thank you so much.
Thank you, Dr. Mithuts, for giving such a wonderful talk. We will be taking questions at the end. So with this, I would like to invite our next speaker, Dr. Benishethi Shantan, who will speak on TKIs in HCC.
Yeah, good afternoon, everyone. Can you see me? Yeah. So I'll share my slides. Yeah, I hope you can see my slides, please.
No, Shantan.
Not yet, sir. Yeah, I can see your slides. Just make it full screen.
Yeah.
You can start, sir.
Yeah, good afternoon. Yeah, good afternoon, everyone. So today the topic of discussion will be on the role of TKIs and in the current era of immunotherapy, where does TKI stand for? So currently, so this is in short the discovery of the discovery or invention of the TKIs, where it started from 2007, where the first landmark trial, the SHARP trial, which showed that the sorafenib was significantly have a higher median overall survival compared to the placebo, or approximately a 3 months over excessive survival in patients with unresectable HCC. So then followed by for the next 10 years, there are no other medications which were found. Then next comes the other landmark trial, which is the REFLECT trial, which showed a comparison of it's a non-inferiority trial, which showed the lenvatinib was non-inferior to sorafenib as a first-line therapy for HCC, with an equivalent median overall survival from 13.6 to 12.3 months. So no other first-line medication has been approved yet, and all other medications, all other TKI tyrosine kinase inhibitors such as the regorafenib, then you have a cabazitaxel, or have been approved as a second line, but none had showed superiority compared to sorafenib as a first-line therapy. Then starts the landmark trials along with the new onset of new inventions of drugs, which such as the immune checkpoint inhibitors. So from 2019 onwards, it's an immunotherapy era where initially the first line starts with nivolumab, but it did not show significant benefit as a first line therapy. Then the first immunotherapy combination which had showed significant benefit is the combination of bevacizumab and atezolizumab as a first line therapy versus sorafenib. So now we'll be concentrating more upon the tyrosine kinase inhibitor. Where do they stand in the current era? So the outline will be the pivotal trials and TKI in patients with along with combination of immune checkpoint inhibitors, TKI in combination trials and TKI historical trials. This is the SHARP trial and the Asia Pacific trial where they have showed sorafenib is significantly beneficial compared to the placebo in increasing the median overall survival. This the SHARP is in the Western data. Even it has been reciprocated in the Asia Pacific trial, which is in the Eastern data, which showed that the median overall survival with the sorafenib was significantly higher compared to the placebo. Then comes the REFLECT trial, where the introduction of lenvatinib happened. This is in 2017, which had compared sorafenib and lenvatinib in the first line treatment, where it's a multi-center international randomized open label trial. So in patient with unresectable HCC, they have taken into BCLC B and C, and but significantly what you can see is only the CTP-A patients have been included, and they have excluded the major component of VP4 tumor thrombosis. The main portal vein tumor thrombosis have been excluded in the trial. They have been stratified, but here the stratification was not based on AFP, which they have done later on after finding a non-inferiority. They were randomized into lenvatinib versus the sorafenib, and basically they have seen that the patient who are receiving lenvatinib is non-inferior to sorafenib when you are seeing at an overall survival rate. The overall median overall survival was insignificant in both lenvatinib and sorafenib, and they have proposed that the lenvatinib was non-inferior. However, if you see the median progression-free survival was around 7.4 months with 3.7 months. But so this was found to be significant, but not the overall survival. So when they have seen how did the tumor behave in patients who are receiving lenvatinib, this is the investigator assessment, then this is the mask independent imaging review assistant. Both have then found that the lenvatinib had statistically significant better anti-tumor effect than sorafenib. Although the overall survival was significantly the same, but the tumor behavior and tumor response was significantly better with lenvatinib when compared to sorafenib. So there was a favorable anti-tumor effect was reproduced in an independent imaging review system when using an M-RECIST criteria. So because they have not initially segregated as per the AFP values, when they have seen in depth into the study, when they have seen that the patients who have received lenvatinib had an AFP more number of patients had AFP more than 200 nanograms per ml, and higher AFP showed a poorer prognosis. So when they have stratified based upon AFP and they have adjusted the odds ratio or the overall hazard ratio based upon the AFP, they have seen that patients with AFP less than 200, the overall survival with lenvatinib was significantly higher when compared to sorafenib. However, also when they have done with AFP more than 200, the overall survival was similar in both lenvatinib and sorafenib. So in patients with less than 200 AFP, the lenvatinib had scored a higher proportion of patients having higher overall survival compared to the sorafenib. So trial may have demonstrated superiority if the patient had been stratified by AFP, but that was not done initially. So what is the specific nature of lenvatinib, which is not there in other TKIs? So lenvatinib is the only TKI which has activity against FGFR1 1 to 4 pathway along with VEGFR 1 to 3 pathways. So if you can see that sorafenib, regorafenib has VEGFR occlusion or blockage, while lenvatinib has VEGFR 1 along with FGFR 1, 3, and 4 blockage. So it is the only TK which has activity against the fibroblast growth factor receptor pathway. So why does FGFR is important in hepatocellular carcinoma? This has been seen that FGFR4 mutation and FGFR receptor is in different cancers. It has been shown that FGFR causes invasion and metastasis along with others inducing angiogenesis, and it's involved in tumor proliferation and anti-apoptosis. Also, the FGFR4 and FGFR19 both are involved in both tumor proliferation and anti-apoptosis, and it is mostly FGFR4 is mostly expressed in the liver tissue, and amplification of FGF19 gene was found to be significantly associated with cirrhosis and increased risk of HCC. So the only TK which can block both FGFR4 and FGFR19 is lenvatinib, and currently that is the standard of care currently going on if patient is not willing or not tolerating any immunotherapy. So the real world studies on lenvatinib in unresectable HCC. So it was a 2018 showed reflect trial. It's a multi-center trial with BCLC, B and C as a population. Only CTP-A has been involved and VP4 tumor thrombus have been excluded. The median overall survival was 13.6 months. And when AFP was stratified in less than 200, it was 19.5 months. The median progression-free survival was 7.4 months. And you can see in this trial, the complete response was only 1%. And the progression was around 15%. 2021 by Kulkarni et al., which showed that the median overall survival in Indian data was 10.4 months, with the median progression-free survival was 5 months. There was no patient who had a complete response. But here, the population also included CTP A and B up to B8, and VP4 has been included. 2021 US by Amit Singhal et al. Group have included B, C, D, and V, and they've included CTP A, B, and C. The median follow-up period was 9 months, but the progression-free survival and overall survival was not reached. However, interestingly, the complete response was showing around 11% in this patient. In this study, there's also a study with Sabrina et al., which showed that 12.8 months was the median overall survival. When showing the reflect criteria, it was 15.6 months, and not meeting reflect criteria was 10.2 months. So what are the newer developments in the treatment of first-line HCC? So there were new developments, new studies, which is lenvatinib plus pembrolizumab in unresectable HCC. There is cabozantinib plus atezolizumab versus sorafenib in advanced HCC. Then there's also KS310 trial, and there's a launch trial, which is a combination of lenvatinib plus TACE in unresectable HCC. Tyrosine kinase inhibitor plus immune checkpoint inhibitors. What is the benefit of adding tyrosine kinase inhibitor to immune targeted therapies? It normalizes the tumor capillaries. It enhances immune cell infiltration and activation in tumors. It reverses the immunosuppression of TMEs, and it promotes the release of presentation of tumor antigens. So this was a study, which is a LEAP 002 study, where I've added on lenvatinib and pembrolizumab and compared with lenvatinib alone as first-line unresectable HCCs. So it is a combination. So it is lenvatinib and pembrolizumab once in 3 weeks versus lenvatinib alone. So it was found that the overall survival was 21.2 months in the combination group and 19 months in only the lenvatinib group. And it was statistically significant based on the number of events. And the progression-free survival, when you see as per RECIST criteria, so it was shown that the lenvatinib versus pembrolizumab has a lesser number of events and compared to lenvatinib plus placebo. And so this is a summary of response in both the groups. As per the RECIST, the disease control rate with the combination group was higher and compared to the patients who were receiving only placebo, but was not much significant difference was seen. So LEAP 002 did not meet the pre-specified statistical significance for primary endpoints and the progression-free survival. So it achieved an overall survival of 21.2 months, which is highest among the groups. And also median overall survival was 19 months, with lenvatinib supports its role as a standard of care in the first-line advanced HCC. The results in LEAP 002 was consistent with the efficacy and safety of lenvatinib and pembrolizumab in earlier studies in advanced HCCs. So combination of lenvatinib, pembrolizumab, and TACE is under investigation in the phase 3 trial. So what is the next trial is phase 3 cosmic trial, which had combined cabozantinib with and without atezolizumab versus sorafenib. So it has combination of cabozantinib and along with atezolizumab. So this showed that the combination of cabozantinib and atezolizumab as compared to the sorafenib has a significant higher, better compared to the sorafenib alone. The overall survival was comparatively equal and there was not significant. So, but when you see the tumor response, the disease control rate was significantly higher with cabozantinib and atezolizumab compared to the sorafenib alone. So this is the another study which had taken TKI into consideration, which is the camrelizumab plus rivoceranib versus sorafenib as a first-line therapy. So this is an anti-PD-1 antibody plus the VEGFR targeted TKI, which is a rivoceranib, also known as apatinib. So there were 543 patients, 1:1 randomization they have taken, and it was found that the median overall survival was 22.1 compared to 15.2 in patients with sorafenib alone. And also the progression-free survival was significantly higher. So where does TK stand when in combination with the local regional therapy? So this is a new BCLC where there are two problem with BCLC, which is a BCLC-B, the third part, which is a diffuse infiltrative extensive HCC, which are not feasible for any local regional therapies. And also there are patients where the patients, even after doing TACE, the patient might be not responding to any of the treatment, which is a failure, which is a TACE refractory patients. So how does the combination of lenvatinib and TACE happen? So the lenvatinib inhibits the expression of VEGF123, which play a key role in tumor recurrence and metastasis after doing TACE. Lenvatinib also inhibits the expression of FGFR, which I've told initially, and play a significant part in the tumor resistance to TACE. It upregulates alternative pro-angiogenic pathways. So with the addition of, so initially with the abnormal, because of abnormal heterogeneous architecture of the microvascular density, so the tumor interstitial pressure increases. After initiation of lenvatinib, the vascular permeability increases, the drug delivery decreases. But after initiation of lenvatinib, the pressure decreases, the vascular permeability decreases, and there is increased delivery of the TACE. So hence addition of lenvatinib before TACE had an add-on benefit. So this was the outcome of initial lenvatinib therapy with subsequent TACE in a subpopulation of primary TACE patients who are primary TACE unsuitable patient. So initially with lenvatinib, initially with patients with only TACE, when there is a multifocal lesions, when doing a palliative TACE, only part of the tumors have been covered with the TACE. So there is decreased response, the liver function is hampered. Also, there is increased VEGFR and angiopoietin 2 receptors, angiogenic growth factors, which increases the recurrence and metastasis. So addition of lenvatinib first has a synergistic effect. So when you start lenvatinib initially, there will be shrinkage and necrosis of few of the lesions. The vessel vasculature gets normalized, and there is improvement of the drug delivery. Then once you do the TACE, post-TACE, the lenvatinib also induces inhibition of VEGF and Ang2 expression, which are induced by the hypoxic state due to TACE. So there is decreased recurrence and decreased metastasis. So there is improvement in the tumor response, and also there is a static nature of the liver function. So in the real world study, there is a retrospective control study which they have seen with the lenvatinib in combination with the TACE, which they have seen that the overall survival rate with TACE and lenvatinib was TACE as in 60 to 60 patients. They have seen that it was the 2-year overall survival rate was significantly higher in the TACE plus lenvatinib group. The progression-free survival was significantly higher in the TACE plus lenvatinib group, and the disease control rate was significantly higher. However, there's increase in the duration of TACE requirement. The duration of number of TACE requirements have decreased, and also there's increase in the duration of TACE requirement in patient with TACE plus lenvatinib group. So also this has been tried in as a novel therapy where they have been using patients, adding lenvatinib in patients who have been receiving RFAs for multiple HCCs. So lenvatinib suppresses the HCC growth, and RFA reducing the tumor blood flow, and RFA will be destroying the lesion which are there. So significant, the frequent RFAs and continued with lenvatinib. So probably there is a possibility of drug-free time when after all the lesions have been covered. In patients with large and multiple HCCs, lenvatinib initiation can cause necrosis of few of the lesions. And the combination of RFA and SBRT. SBRT is typically used for those sites which are difficult to puncture, cannot be suppressed with lenvatinib. And addition of lenvatinib had a synergistic effect in covering all the lesions of HCCs and in achieving an overall survival along with the complete disease control rate. So this combination therapy with lenvatinib and radiofrequency ablation for patients with intermediate stage HCC, which are beyond the up to 7 criteria, and Child-Pugh A, which is a pilot study, which showed that the combination therapy has a higher progressive-free survival and higher overall survival compared to patients who are received only TACE or only monotherapy. So this is a launch trial, which is a randomized control trial, which they used the lenvatinib plus TACE versus lenvatinib alone as first-line treatment for primary advanced hepatocellular carcinoma. So they have randomized into 1:1 and around 168 patients in both the groups. So this was the overall scheme where before 14 days, there was initiation of lenvatinib and followed by TACE. And there was the TACE was on-demand TACE as and on whenever the lesion was evaluated after 1 month or after 3 months. So and the lenvatinib has been continued and the patient have been followed until survival. So what was the results based upon this criteria when we compared with RESIST or versus mRESIST? It has been shown that the objective response rate and the disease control rate was significantly higher in patients with lenvatinib and TACE group when compared to lenvatinib alone. And overall, the patient also had a complete response in lenvatinib and TACE group with 5:1. And also there were patients who had a higher number of partial response patients in patient with lenvatinib and TACE group. And when you see the overall survival, the median overall survival was 17.8 versus 11.5. And the median progression-free survival was 10.6 months versus 6.4 and was significantly benefit. Statistically significant difference was seen in patients who have received a combination therapy. So as per the launch trial, so the lenvatinib plus TACE was safe and effective for patients with advanced HCC. It demonstrated remarkable improvements in overall survival, progression-free survival, as well as acceptable toxicity. Lenvatinib plus TACE may represent a potential new first-line treatment option for patients with advanced HCC who are not fit or who are unfit for patients who are receiving immunotherapies. So these are all the first-line therapies for unresectable HCCs. So, the latest ones are the launch therapy, the LEAP, and the case 310. But also, it was only positive for overall survival only. As a second line, what's the role of TKA? These are the old studies which have been done, which is the Celestial study, the Resource, and the REACH2 study, which had shown the response of cabozantinib versus placebo as a second line therapy was significantly better. Regorafenib versus placebo and ramucirumab versus placebo. However, the overall survival rate was just marginally 2 to 3 months above than the placebo, but also has a significant adverse effect. So these are the drugs which can be used as a second line TKA agents. So I would like to conclude that TKA had shown effectiveness as first line as well as second line treatment. Lenvatinib is most likely to have better efficacy and tolerability compared to sorafenib, but still has a role in the first line HCCs. Lenvatinib plus TACE combination appears to be a good downstaging strategy for advanced HCC patients, such as specifically the BCLC-B, which has a multifocal lesions. Combination therapy of TKI and immune checkpoint inhibitor may open a new vista. However, patient selection will be an important criteria. Patient performance status, underlying liver condition, and other comorbidity and cost-benefit ratio will be an important factors to determine the first-line therapy in our population. Would like to end. Thank you for the opportunity, and any questions I will be happy to attend.
Thank you, Dr. Venishetty. Do we have any questions? Okay, so let's proceed with our next talk, which will be given by Dr. Deepak Kopakka. And the topic is role of atezolizumab and bevacizumab in METAS.
Yeah, is my screen visible?
Yes, sir.
Yeah, and thank you. And actually, after such an extensive talk, I don't know if I'll be able to justify
the further discussions in this topic. I'll be talking about is it visible? Problem with this?
So your slide is visible.
Sorry for the technical glitch. My topic is a relatively old topic, and the topic that actually established the standard of care in unresectable locally advanced HCCs. So it is the role of itolizumab and bevacizumab in first-line unresectable HCCs. After such an extensive talk by both my prior speakers, I think we understand that liver cancer is now increasing globally, and the mortality is still on the rise. Uh, the incidence is highest in the developing regions, predominantly from the Saharan countries. And also in India, we see that the numbers of HCCs are on the rise. It accounts to almost 90% of all liver cancers. The other 10% of liver cancers are either intrahepatic cholangiocarcinomas, angiosarcomas, and hepatoblastomas, which are more common in the pediatric age group. And as we all know, the most significant risk factor for HCCs is the presence of cirrhosis. And 80 to 90% of all HCCs arise from the cirrhotic liver, whereas 10 to 20% of HCCs do not arise from underlying cirrhosis. So this is the Indian scenario. There are around 35,000 new cases of liver cancer in India from in 2020, and it is the 10th most common of all cancers. And it's the 8th most common cause of mortality, with 33,793 patients dying due to liver cancer in 2020. It's an unmet need. Majority of the patients are detected like most of the other cancers in advanced stages, and the 5-year survival is very dismal with 2 to 2.3%. And most often the TKI remains the standard of care in our patients because of the cost constraints with use of IOs and VEGF inhibitors. And so now coming to the approvals for metastatic and advanced HCCs, the earliest approval was with sorafenib, like in the earlier talk that was discussed, and it almost took a decade. It took a decade for us to have a significant change in the lines of treatment. There was a non-inferiority study that was discussed earlier with lenvatinib, but the study that has significantly changed the way we treat metastatic and advanced HCCs is the use of atezolizumab and bevacizumab, which has shown both PFS and overall survival advantage, and now remains the standard of care. Over the last 2 to 3 years, we've again seen a slight increase in the newer approvals in upfront setting with the use of IO combinations, uh, uh, and also use of IO VEGF combinations in post-stage setting. But again, that's for a different day of the discussion. But this is what is the current standard of care in first-line setting. That is sorafenib, lenvatinib, and etozobev remain the standard of care. So the rationale for combining atezolizumab with bevacizumab in HCCs, as we all know, is the cancer immune cycle. And use of a VEGF inhibitor, like was discussed in the previous talk, like with TACE, where we streamline and decrease the intra-tumoral pressure. Similarly, we see with the VEGF inhibition, there is normalization of the tumor vasculature, which allows better penetration of the immune cells into the tumor and leading to better tumor control. So itolizumab promotes the T cell activation by inhibiting the PD-1 axis, whereas bevacizumab causes normalization of the tumor vasculature, increasing the T cell infiltration, decreases the activity of the immunosuppressive milieu, that is the MDSCs and Tregs within the tumor microenvironment, and it promotes the dendritic cell maturation. Whereas atezolizumab by T cell activation restores the anti-tumor activity. So that is the basic science part of it, which laid the foundation for the use of this regimen in HCCs, and also in lung cancer. This remains the reason why atezolizumab is combined with a VEGF inhibitor. And now, as we see that the same principle is used even with Emerald data, where bevacizumab is combined with durvalumab in the post-stay setting, which has shown a significant PFS advantage. So I think that is the right way of combining IO drugs, either IO plus VEGF inhibitors or immunotherapy activation at two places, that is at the CTLA4 activation and at the tumor microenvironment. If the T cells are activated, they lead to better tumor control and better improvement in overall and progression-free survival advantage. Single agent immunotherapies have not shown great results in the upfront setting and have shown benefit in the second and later line of treatments in HCCs. So now coming to the IMbrave 150, which is the pivotal trial that actually laid the foundation for the use of atezobev in unresectable HCCs. Patients were stratified, around 500 patients were enrolled and were stratified based on the region, Asia, excluding Japan versus rest of the world, ECOG performance status, MVI and extrahepatic spread, and baseline AFP. So based on this stratification, patients were randomized on 2:1 fashion to atezo and bev given at a doses of 1200 mg and 15 mg per kg 3-weekly dosing versus sorafenib 400 mg twice daily. The primary endpoint was overall survival and PFS, and the secondary endpoints were overall response rate. So the study was relatively well balanced across the different groups. But as you can see here, there were a significant proportion of patients in BCLC-C, very few patients in BCLC-B, nearly 15% of the patients with BCLC-B. Most of the patients have Child-Pugh score of A5 or A6. And hepatitis B and hepatitis C positive HCCs were accounting to almost 70% of the cases. AFP more than 400, like was discussed in the previous talk, only around 1/3 of patients had AFP more than 400, which predominantly these group of patients are predominantly VEGF dependent tumors, and we have significant data coming with the use of VEGF inhibitors in this patient population. Patients having extrahepatic spread and major vessel involvement was almost as high as 75%. And a very interesting part of the study was prior local therapy was used in nearly 50% of the patients. Unfortunately, the data that we've analyzed, the limited data that we had in our practice, most of the patients with HCCs receiving prior local therapy is relatively low in our practice, at least. That is predominantly because most of these patients come with either significant involvement of the major portal vein or with having extrahepatic spread, that is lymph node spread and metastasis to lung or bone. So the study met its primary endpoint, one of its primary endpoint being PFS. There is almost a 40% risk reduction for progression with the use of atezo-bev compared to standard of care sorafenib, with PFS being 7 months versus 4 months. And once we see at the time of progression, patients with sorafenib nearly almost 1/4 of the patients received immunotherapy in later lines, and most of these patients received tyrosine kinase inhibitors in later lines. Whereas with patients with atezo-bev, most of these patients received TKIs in second line of treatment. One very interesting and practically relevant point here is, as per the trial, where we see that the trials recruit the fittest of the fit patients into the randomization. We can see here at the time of progression, only 30% of the patients on atezo-bev go to second line, and only 10% of the patients from there on go to the third line of treatment. More or less similar pattern that we see even in practice, that at progression, there is a rapid deterioration either because of the underlying cirrhosis or the general performance state of the patient deteriorates, and very few patients are fit enough to take later lines of treatment. Third line, very few patients eventually end up taking third lines of treatment in practice. Now coming to the overall survival advantage, again, nearly almost a 40% risk reduction in death was seen with the use of atezo-bev upfront. The mature data was later presented with almost 1.5 years was the progression of median OS in the atezo-bev arm compared to nearly a year, that is 13 months in the sorafenib arm. So this is the updated OS data. The median OS was around 19.2 months versus 13.4 months, which was statistically significant, laying the foundation of this study being the standard of care. A consistent benefit was seen across the tumor types, irrespective of the AFP levels, the stage of the patient, hepatitis B, C positive. All of them unanimously derived significant benefit in terms of overall survival and also in terms of progression-free survival. This one arm, which was the BCLC-B arm, was only around 16%, and as we can see here, the confidence intervals are very wide. So I think we need a much mature data. And now taking the BCLC-B patients separately, we can see that most of these patients, the current standard of care is evolving towards the use of either lenvatinib, like discussed in the previous talk with the launch data, or with the Emerald data. I think there is use of systemic agents even in BCLC-B patients pre-TACE or post-TACE, though not the standard of care. I think that is where it is eventually heading, the management of these patients. We can see a doubling of response rates. Even the updated results show that almost a tripling of response rates from 30% versus 11% was seen as per the RECIST criteria. One very interesting part here is as discussed in the previous talk, we don't see CRs with use of TKIs, whereas with Etizobev, there was a significant proportion of patients who achieved complete responses, and the median duration of response also significantly increased with the use of Etizobev. Side effects now, because there is a combination of Etizo and bevacizumab given, most of these patients had significant toxicities because of the immune component of the treatment, or also because of the VEGF component of the treatment. But adverse event leading to withdrawal from any component, though being 16 in the Etizobev arm, both components were withdrawn only in 7% of the patient population. That is actually very low. And even in practice, we can see that is relatively well-tolerated regimen. Hypertension, diarrhea are relatively more common with the Etizobev combination, whereas with sorafenib, the Hanford syndrome, diarrhea remain the most common complications with these treatments. One concern that we have with both sorafenib or lenvatinib, which are VEGF inhibitors, along with bevacizumab, are the risk of bleeding. And these patients, because of the underlying cirrhosis, have a significantly higher risk of variceal bleeding. The study analyzed whether there was an increased variceal bleed with the use of Etizobev, and it was not very high. It was more or less similar to what we see with VEGF inhibitors used as TKIs. Other complication is hepatitis, which could be autoimmune hepatitis or because of the underlying cirrhosis. Both lab abnormalities and clinical hepatitis, other than the lab parameter derangement, were relatively similar between Etizobev and sorafenib arm. But again, we can see that there are a lot of patients who have predominantly lab abnormalities than clinical diagnosis. That predominantly might be because of the underlying cirrhosis that these patients have. So there was regarding the time to deterioration and quality of life. Again, Etizobev had better quality of life. As we can see, Etizobev had relatively lesser Hanford syndrome and diarrhea, and more of hypertension, which could be managed with pills. Sorafenib had more deterioration in the quality of life as the patients continue to use these treatments for a longer time. So side effect wise also, there is better physical functioning that was seen with Etizobev compared to sorafenib. So because of these factors, I think the treatment options in most of our patients with those are diagnosed with HCC, which is locally advanced or post-TACE failure, now remains Etizobev. The only concern with use of Etizobev that we encounter in practice is the variceal bleed, but I think with good support from the hepatologist or from the GI team in the hospitals, the gastroenterology team within the hospitals, with banding and all, we end up treating most of these patients with Etizobev in practice. So consistently across guidelines, Etizobev remains the standard of care in patients with metastatic and post-TACE failure HCC patients. So regarding the later lines of treatment, if the patient have responded or were on VEGF inhibitors upfront, and if the patient's progress, we tend to use Etizobev, but the data did not really incorporate those group of patients post progression of sorafenib and lenvatinib. At least in my practice, I have a couple of patients responding durably long for more than a year's time with Etizobev post exposure to lenvatinib. So even the INSL guidelines recommend Etizobev as a safe and effective treatment for first-line systemic therapy in metastatic locally advanced HCCs. So thank you, and I'm open for any questions.
Thank you, Dr. Deepak. Do we have any questions? Okay, so let's proceed with our next talk, which will be given by Dr. Anand V. Kulkarni. on selection of right patients for immunotherapy.
Am I audible?
Yes, sir, you are audible.
So I need to discuss an ideal candidate for systemic therapy, although this has been expanding. Initially, it's all basic trials which were done in patients with HCC were only limited to patients who have advanced disease but good performance status and good liver function status. I'll be discussing about few studies where I'll be touching upon who are the ideal candidates where they chose systemic therapy and what are the expanding role of systemic therapy and who will be a candidate for systemic therapy. Next slide, please. So here we'll be discussing on BCLCC because this is the area where actually we use systemic therapy. And what is our aim? We have been shifting from palliative care to provide a more, probably a curative option for this patient with liver cancer who may also undergo liver transplant and have pretty good survival at least for 5 to 10 years post-transplant. And how to achieve it and which are the drugs which are available, which has been discussed in the by the previous speakers, but I will just touch upon it. And what is the role of combination local therapy and the systemic therapy for patient with BCLC? Next slide, please. This is the BCLC which we know of previously, where BCLC said that in the States, we use systemic therapy, and almost for a decade or so, we had only 1 or 2 drugs, where the survival is hardly 10 months. And none of these patients, as the previous Dr. also mentioned, that none of them achieve complete response and they may not be able to have a long-term survival. But with the currently available IO agents or the combination of IO and local systemic therapy, we have been able to achieve a good survival of up to 2 to 2.5 years in select group of patients. If they don't respond to IO, probably the next line of therapy will also be IO in the coming year. But as of now, we have been sticking to TKIs. And usually, as Dr. Deepak also mentioned, in the third line, we have very few options. But given the availability of several drugs, we have been using one or the other drug. But if the person doesn't respond to first line IO therapy, they will not be responding to any of the subsequent TKIs or the IO therapy. Next slide, please. So the INASL has modified slightly the BCLC classification. They have made it into C1 and C2 stage, where C1 is portal invasion without extrahepatic spread, and C2 is extrahepatic spread. Irrespective of this, as BCLC only mentioned BCLC for systemic therapy, and in initial studies also, all BCLC B and C were included for systemic therapy. Here, if you see, they are clearly mentioned that patients who have B2 and B3 stage, that is intermediate stage and advanced stage, they are also ideal candidates for systemic therapy. Most of these patients end up undergoing a combination of local therapy and systemic therapy. Next slide, please. And also in that previous slide, if I have to say who is not ideal candidate, it's BCLC-D, where the performance status is very poor, the bilirubins are high, the patient has gross ascites, and is not a candidate for any of the therapies. They should not be touched at all. Anyway, their survival is less than 3 months. We have shown this in a recent publication in our one of the journals, saying that patients who receive with advanced liver disease, they have very poor survival. So aim in HCC for a long time, we had only aim to prolong the survival of these patients, but now they have changed from being just giving them a good survival also. The aim is to improve their quality of life and also to achieve probably long-term survival. Next slide. And also prolong the cancer-free drug. And the aim is actually here is to make the patient cancer-free and drug-free, improve the quality of life and prolong the overall survival. Next slide. This is the evolution of drugs. This has been discussed several times, but we have been seeing newer drugs day in and day out. There are many IO agents which have been added to the guidelines now, NCC and BCLC, EASL, ASLD, all of them have come up with newer drugs. The one which is available in India is atezolizumab and bevacizumab, and the second one which is available is the combination of single dose of tremelimumab and the multiple dose of tremelimumab. So based on these studies, probably ideal in these trials which they have conducted, Himalaya trial or the IM Brave 150, all of them, they have included only patients who have HCC in the early phase, good performance status and preserved liver functions. Next slide. Inclusion criteria is BCLS B or C and child A, good performance status, and not received any prior systemic therapy. This is one concern. Most of our patients, especially in tertiary care hospital, they come with they have taken some exposure to either lenvatinib or sorafenib in the initial stages. Then they progress, then they come to us. As the previous speaker also mentioned that despite changing from TKS to IO, they do respond very well and their long-term survival is excellent. Next slide. The mechanism of actions of these is little different. That's the reason they have they prolong they give a better survival for these patients. TKI just try to kill the tumor cells, acting at multiple tyrosine kinase inhibitor points. While the combination of IOs, they act at multiple points, they improve the immunity of the individual and also try to kill the cancer cells. Next slide. If I have to compare the previous two speakers, who is better, TKI or IO, this has been just simplified in this slide, saying that the TKIs have the advantages. They are quite economical, easily available. They have decent overall survival up to 11 to 12 months. In the recent studies, they say up to 18 to 19 months. There are no unusual adverse events, easily available oral drug. But IO has the advantage that complete response is possible. They have excellent overall survival. They can act as a bridge to transplant. There are multiple studies. Recently study, it said vitality study, which said that patients who receive IO can almost 30% of them can also undergo transplant later on. Disadvantages, both of them have some disadvantages. Like PKs, there are some adverse events. Common adverse events include hand-foot-mouth syndrome and oral rash, and these patients also have hypertension and proteinuria. And you cannot act as a bridge to transplant. While in IOs, they are not economical. That's a major disadvantage. It's not easily available. Yes, definitely it's not available everywhere. Unusual adverse events, especially we struggle managing their immune checkpoint inhibitor related autoimmune complications. Post-transplant use is definitely has strong data for TKS, but not for IO agents. There are some studies where they say that more than 2 years after the transplant, we can initiate IOs, but the response has been considerably low. Adverse events with TKIs are actually common adverse events, that is diarrhea, hypertension, hand-foot-mouth syndrome, and proteinuria. Well, IOs have actually the more commonest adverse event. What we see is fever and fatigue, the commonest one. There are some drug reactions which can occur with these drugs. There is also proteinuria and hypertension with this IO agent as well. Next slide. But we actually prefer IO over TKI because the complete response is definitely there and the patient can be taken up for transplant later on. Next slide. Recent data on these IOs have shown that they provide excellent survival. If we choose a candidate, ideally, if the candidate is fit enough to tolerate these IOs, their survival is pretty long. When I say fit enough, I mean that the performance status should be good. If they have poor performance status just because of the tumor, they may also be a candidate for giving this immunotherapy. They are used for such patients where the patient was bedridden only because of the pain in the right upper quadrant, a large tumor where we had to initiate this therapy, and we found that almost the patient survived here for 2.5 years. And the tumor had complete necrosis after around 6 to 8 doses of atezolizumab. Next slide. Next slide. I think I mentioned this both. The recent drug which was approved where the STRIDE is a combination of the two drugs where they have shown that long-term survival is definitely there. But there is no strong data from atezolizumab, but we in real world actually have good data to say that they really have long-term survival in these patients. It's not necessarily only one drug. Both the drugs have similar efficacy. Deep remission and prolonged remission is known for both these drugs. Next slide. So, as I say previously, that if I compare these two drugs, TKIs versus IOs, I think IOs win over in multiple efficacy points and safety points as well. But only thing is difference is the economical aspect, which is very poor with IOs. Next slide. As I said before, the transplant is definitely feasible. Multiple studies have proven that you can do transplant for this patient. There is strong data for nivolumab, where they said 60 to 90 days should be the duration gap between the last infusion therapy and liver transplant. Rejection is a feared complication because we are trying to activate the immune system of an individual while we give some immunosuppressants post-transplant to prevent rejections. So there are several studies, next slide, on the combination of atezolizumab. There are also studies which have shown that there is good amount of data to support the use of these drugs pre-transplant. We have burnt our hands by using these drugs in post-transplant period, but we are not comfortable using these drugs post-transplant. Pre-transplant, definitely, yes. With this, we have to, our data from AIG has shown that out of 100 plus patients who received immuno-oncological atezolizumab therapy, 10% were downstage and they could undergo liver transplant later on. Next slide. Next slide, please. So here, if you say it can act as a downstaging modality where we treat patients with advanced liver cancer. What we did here was basically take all the patients who have received the therapy and then identify those who were downstage to become into either UNOS double downstaging criteria or the Milan's criteria. And then see how many patients of these underwent transplant. Almost 10 to 12 patients could be downstage, but very few underwent transplant. There were some infections. SBP was common in these patients, so they were downstage and they were waiting for liver transplant. What we also did here was we assessed their biomarkers. So for ideal candidate, who is ideal candidate? Very difficult. If I say we also assess these PD-L1 levels in the blood and then check whether the PD-L1 levels are very high, then these are the patients who will respond to therapy. If the PD-L1 levels are low, then these are not the patients who will respond to immunotherapy. So identifying ideal candidate is also dependent on biomarkers, the age of the patient. The age of the patient has been controversial. Some say that age more than 65 will not respond, but there are few studies published in Liver International and Hepatology International saying that these patients, irrespective of the age, they respond well. The highest age we have treated is 93 years who responded to the atezolizumab therapy and survived for almost 1.5 years post the diagnosis of recurrent HCC in the patient who had undergone TS prior. Next. So here we see that almost 12 out of 23 patients had undergone downstage to transplant. There are multiple studies which have been ongoing on ICS as a role of downstaging modality. Some of these have been listed here: the Plenty trial, the immunoXXL study, the ESR study on immuno-oncological agents and transplant. Next slide. So systemic therapy in HCC, the guidelines say that if the patient is child pug and is suitable for IO, then either if the patient is unsuitable for anti-VEGF, that is the risk of bleed, then we have to take a call on durvalumab and tremelimab. If the patient is suitable, then we go ahead with atezolizumab. If the patient progresses on this, then we change into lenvatinib. When I say unsuitable patient for IO is basically patient who has significant history of autoimmune diseases are the patients who have actually contraindication for IOs. If the patient has poor quality of poor performance status, elderly patients, child pug, current guidelines recommend only durvalumab as a single drug of choice because tremelimab has a lot of adverse events and atezolizumab as a IO agent also has few adverse events in elderly patients with poor performance status. Next slide. The combination of TS and TK has been tried to achieve a comparable survival to those which has been given with IO agents. But there are some data which are upcoming, like Emerald data on this, which has shown the significant survival benefit with the combination of IOs plus TS in these patients. Next slide. LRTs and atezolizumab, when I say the combination has worked pretty well in these patients, especially the SPRT and the TARE have been found to be beneficial because when we do these procedures, there is enhanced neoantigen expression on the tumors, which can be targeted by the IO agents. Next slide. These are all these studies which have been done on the combination of IOs plus leucorenal therapy. Here, if I say again the pre-inclusion criteria in these studies were child pug A to B7, BCLC A, and intermediate HCC, basically who has good child A and early child B with a tumor diameter, irrespective of the tumor diameter. There should be no extrahepatic mets. If the patient has portal vein thrombosis, we treat them with local therapy, then add some systemic therapy. So there is expanding indications and expanding role of the systemic therapy in real world. although the studies have been performed in very limited and small, very narrow criteria, in real world, we actually tend to use them quite rapidly and quite rampantly, and we have found very excellent results with this use. It's not necessarily that the patient should be in childcare, because if you see any of these patients, they usually present with advanced disease with advanced child's score. If the patient only has mild ascites, bilirubin around 2.3 with in a 2.3 or 3 with indirect hyperbilirubinemia, you can still take them for giving IOs or systemic therapies. They're all ideal candidates. Only clinical sense can give a patient who is an ideal candidate for you. It's quite difficult to predict anyone who can not survive with these drugs. But good performance status is definitely will required if the patient has hyperbilirubinemia only just because of the tumor burden, or the patient has viral reactivation. If we are suspecting hepatitis B and the patient has viral reactivation related hyperbilirubinemia, then he may be treated and then taken up for immuno-oncological agents. Next slide. This is again on the combination of SPRT and IO, saying that we can use these combinations in BCLC and B, where the patient has good performance status. Next slide. The combination of TKIs and IOs have not been successful in in those studies where they have compared either lenvatinib plus TKI, they have plus IO. They have shown that there is comparable overall survival in using a single agent or the combination of these drugs. I usually don't prefer the combination of these drugs because the side effects are pretty more, and the patients tend to drop out of the treatment arms. Next slide. What we usually do in BCLCC is we usually combine LRT with systemic therapy. If the patient has portal vein invasion, we do SPRT. There are multiple intrahepatic tumors. We selectively ablate them and then add systemic therapy. So extrahepatic meds we usually take care through either ablation of these tumors or just add systemic therapy to those patients. So if you ask me who is an ideal candidate, if possible, if the bilirubin is low, everybody is an ideal candidate for tumor systemic therapy. Do not leave them. If they respond pretty well. If you have the facility to assess for PDL1 levels, which we have been doing in our hospital, probably they will give good results. If you know that PDL1 levels are pretty high, they are the ones who will usually respond to therapy. But we have been lacking markers who can develop complications because of systemic therapy. We have been only able to assess the response, but not the complications. Complications also are the ones which have been struggling to identify good biomarkers. Multiple studies from Japan have been conducted. The IMBRAVE group also published that if you do a biopsy of these tumors, you might find tumor infiltrating cells, CD8 predominant cells. In the patient has CD8 predominant infiltrating cells, they will probably respond good to the therapy. But the hardcore problem here is response is just okay. We can assess it with the imaging after 3 or 4 doses, but complications are the one which we struggle. If the patient has any decompensation, sepsis, post immunotherapy, that is when we lose the patient for the combination. Next slide. Next slide, please. So in a nutshell, who is an ideal candidate for systemic therapy? He is a candidate who has good performance status, less than 2, ECOG, BCLC-B or C. Child per A, we treat up to 8 only if the bilirubin is less than 3 milligrams per deciliter. Or the etiology of the tumor or the tumor burden, that doesn't matter. Larger tumors, even the IMBRAVE subgroup analysis showed that larger tumors can also respond to therapy. When you're treating with ICS, it's better to rule out autoimmune disease for these patients. For atezolizumab, it's must to evaluate for varices and then add beta blockers auristatin for these patients. For those who have ramucirumab, plan for ramucirumab, there should be alpha fetoprotein should be more than 400 because this drug failed in a study in patients who had alpha fetoprotein less than 400. Basically, if AFP is more than 400, there is higher vascular infiltration, higher expression of VEGF, where ramucirumab can work. So these are all the ideal scenarios where you can use systemic therapy for those patients. Thank you. Any questions, I'll be happy to answer.
Thank you, Dr. Anand. Next is case study presentation by Dr. Arif Khan. We can take questions afterwards.
Can you present the slides, ma'am? Share the slides. So, good afternoon, everyone. What I will be doing is discussing a case about which we treated in our institution. So, basically, a case is a 70-year-old man from Darjeeling who was incidentally detected to have liver SOL on the routine ultrasound which he underwent at local place. The suspicion was also the involvement of the portal vein with the thrombus. So then he came here to our institution. Next slide. So basically, when we look at the HCC presentation, what is the median age of presentation? Globally, it is around 75 years. In US, in males, it's around 60 to 65. In females, 65 to 69. In the Egypt, in the African countries, it is far less. They present in a younger age, as around 58 years. In African countries, other than the Egypt, it's around 46 years. So in the Western side, the median age of presentation is around in the 6 to 7 decade. In the African countries and also in the Asian countries, it's more younger patients develop this HCC. It's around the 4 to 5th decade. So that has some implications in the prognosis because the younger the age, basically it tells that the tumor is going to be aggressive. In the older age, it's not so aggressive. There is a common notion in the oncology that younger the age, the aggressiveness of the tumor increases. So let's see in the Indian data, but let's analyze it. So next slide. So the epidemiology of the HCC is changing. So previously, we used to see the patients in the older age, maybe in the 6th or 7th decade. Now it's presenting in the 5th decade. So the median age in one study was found to be around 52 years, and majority of the patients had cirrhosis attributable to the HBV infection. So around 60% patients had cirrhosis, more related to the HBV virus. So next slide. So when we analyze the baseline characteristics of the different studies, as we can see here in one study by the Duseja et al., we can see the age is around 60 years. Majority of them were males, and the common presentation symptoms were abdominal pain, loss of appetite, and loss of weight, along with ascites. And majority had a cirrhosis of liver, around 86% patients. Non-cirrhotic liver was found in only 14% patients, and the causes for the cirrhosis were HBV was predominantly found 53%, followed by NASH. So NASH is actually emerging as a major risk factor for the development of cirrhosis. Those who do not have this HBV virus, and also non-viral etiologies are increasing nowadays. And the AFP, which at presentation is the range is around 10 to 640. It's around the mean range is around 100 nanogram per ml. So in another one study done by Dr. Anand, those patients who were given lenvatinib on 63 patients, the median age was around 60 years, matching with the Western data. And also the predominant patients were males. The etiology was almost equally distributed here. The hepatitis B was 20%, HCV was not so common, 10%, and NASH related liver disease was around 28%. And alcohol nowadays, that's not a major risk factor for the development of cirrhosis. And those patients, around 55% patients had multicentric HCC in this study. So next slide. So coming to our patient here, he presented with right upper quadrant pain along with a loss of weight around 5 kilos in 1 month and with loss of appetite. So these were the presenting symptoms of our patient. So next slide. Next slide. So the presenting illness, we see that the pain abdomen was found since 1 month. Basically, the right upper quadrant pain, that's what we expect in HCC with no aggravating or relieving factors. It was dragging type pain, continuous, relieved by some analgesics, and also he complained of bloating with distension and also had the third space collection, pedal edema. These were the presenting symptoms. The next slide. He had comorbidities of diabetes, hypothyroid, and also had hypertension since a long time and no significant surgical history. Next slide. So when should we suspect HCC in a patient who has cirrhosis, has already a chronic liver disease, maybe viral, non-viral? We are following up these patients, but what are the alarming signs and symptoms where we should be having a high index of suspicion is worsening of ascites. Already patient is doing well, he has a compensated liver disease, but recent onset worsening of ascites should raise alarms about the whether the patient has already started developing the tumor. So loss of appetite is one of the, though it may be attributable to CLD patients also, but the excessive loss of appetite, excessive fatigue, and the patient has developed again ascites. Despite having a third space collection, the patient has developed weight loss. These are some of the alarming signs. And rising AFP, again, biomarker where we should raise the high index of suspicion for the development of HCC. And patient is doing well for many years. He has a compensated CLD, but recently has developed the decompensation. Then we should suspect the development of HCC and also the rising of the alkaline phosphatase levels. So next slide. Coming to personal history, the patient is married, his appetite is reduced, he has a low calorie intake, there is no significant family history as such. These are the personal histories. So next slide. On examination, patient had pedal edema, pitting pedal edema. The rest of the parameters were almost normal. He was conscious. Did not have any signs of hepatic NCAF. And moving to the next slide. So liver and was enlarged, he had hepatomegaly and also splenomegaly, and the rest of the systemic examination was within normal limits. So next slide, madam. So hemogram was normal. The creatinine was somewhat raised, 1.65. LFT was showing elevated alkaline phosphatase around 168. So as we discussed, the alarming signs, alkaline phosphatase, rising alkaline phosphatase in CLD patient should bring us the suspicion of the HCC. And the INR was almost 1.3 normal. Again, PUCA was raised to 2025 and AFP was not so not high, so it's just 9.3. Endoscopy showed varices except for the lags LDS. So next slide. So AFP is a strong tumor marker. We know that the diagnosis of the HCC need not be biopsy based. So it's usually the suspicion on the radiological suspicion, the arterial enhancement, and the venous washout, which we consider as the one of the diagnostic criteria for the HCC, along with the AFP more than 200. That was the previous criteria. Now, when should we use AFP as a diagnostic marker? So at the value of around 20 nanogram per ml, it shows a good sensitivity but low specificity. whereas the high cutoffs more than 200, though the sensitivity drops, it becomes highly specific. So the lesser values are sensitive but not specific, but more than 200, it's specific but not so sensitive. So that's how the AFP should be analyzed while diagnosing the HCC. So next slide, madam. So this is again the flow chart of diagnosis of the HCC when we are doing a routine ultrasound in any CLD patient, and when we find the FV of more than 20, look at the sizes of the tumor is less than 1 centimeter. He can be put on close surveillance. That just monitor with the routine ultrasound and the AFPs. And if it is between 1 to 2, we consider some imaging study apart from ultrasound, like any triple phase CT or triple phase MRI, to pick up the tumor in the earlier stage. And if it is more than 2 centimeters, again, we look at the imaging, dynamic imaging, and either the triple phase CT or MRI. Again, if it shows a typical pattern, then we treat as HCC, then atypical pattern, then we consider biopsy. If the AFP is not suggestive and even the imaging is not suggestive, then we go for biopsy if there is a high suspicion of HCC. Next slide. So the CT criteria is arterial enhancement along with venous washout. There's some of the confounding diagnosis which we can see the differentials like hemangioma and focal nodular hyperplasia. We can easily distinguish them from the HCC because of the pattern of enhancement. The washout with the in the venous phase is not seen in the hemangiomas and focal nodular hyperplasias, and this diagnostic criteria, radiological criteria, is very sensitive and also specific. The overall sensitivity is around 89%, and the specificity of this diagnostic criteria for diagnosing HCC is 90%. Next slide. When should we be considering a PET CT in the diagnosis or in the staging? So though these tumors are not so FDG avid, they are have very low FDG uptake. This is because the tumor cells express the P glycoprotein, which leads to the efflux of the FDG out of the cells. And the more differentiated the HCC is, lesser is the accumulation of the FDG. So the FDG should not be routinely used in the diagnostic staging, where when we consider that the patient has higher tumor burden and the AFP is very high, more than thousands. So to rule out the metastasis, the PET CT should be considered, and the FDG uptake is observed in less than 40% of HCC patients. So next slide. So it should be used as a complementary imaging as to the triple phase CT. And what are the indications for doing FDG PET is high AFP, as I discussed, to rule out the meds. If we are ruling out, so some you are considering the secondaries in the liver to rule out the primary, then we should be considering the PET scan. And also, when we find a liver SOL in a non-cirrhotic liver, and there is we suspect the other diagnosis, then we should be considering PET in these cases. So PET scan has a high sensitivity for detecting the extrahepatic mets, but low sensitivity for the primary HCC. So next slide. So triphasic MRI again is the gold standard. It should be considered in all the doubtful cases where the diagnosis is not clear. It actually picks up those patients who have also thrombosis, and these were the investigations done in our patient, the triphasic MRI showing a tumor when thrombus and PET-CT was not showing any meds. There were no distant meds. So huge liver lesion in segment 7 and 8 with the thrombosis it's extending up to the portal confluence and adjacent part of main portal vein. This was the imaging findings of our patient. So next slide. So when we summarize, so the patient was actually having chronic liver disease, NASH related, did not have any varices. He had preserved liver function, Child-Pugh A6. He was having a very good performance status, PS0, BCLCC because of the involvement of the vein and with comorbidities which were pretty much controlled. So next slide. So what are the options? So one of the straightforward option, okay, if you follow the BCLC algorithm, then systemic therapy should be considered. Usually the IO agents are the preferred drug of choice. If they're not affordable, if can't be used, if they're having contraindications to the IOs, then a TKA should be considered. So what are the emerging role of these liver-directed therapies even in the advanced stage? They have got a role now, as discussed by Dr. Anand, also giving SBRT to the tumor thrombus. This controls the tumor vein thrombus, and it also enhances the neoantigen expression in the tumor. So after that, we can give immunotherapy, which can boost the tumor immunity, and both these can act synergistically. So that is the emerging role of liver-directed therapies, even in the advanced stages of the tumor, which are not clearly mentioned in the guidelines. Surgery, transplant are one of the options in the advanced stage when the tumor has already involved the tumor that it has already developed the thrombus in the portal vein. So these are some of the options. So what we did in this patient, let's see in the next slide. So next slide, please. Again, the BCLC algorithm, which has been extensively discussed by previous speakers. I will be skipping this slide. So next slide. So what our patient underwent tear. So one of the liver-directed therapy again, since he was a very preserved function patient. So the liver function was Child-Pugh A, and he did not have any comorbidities, and also the liver functions, organ functions were normal. So he was started on tear. One session of tear was given, followed by immunotherapy for 3 sessions. That is atezolizumab and bevacizumab. After completion of 3 cycles, let's see it for the response. So next slide, please. So when we did the scan, it showed actually a very good response. The tumor had shrunken, and also the thrombus, extent of thrombus had very much decreased. That's how this difference is seen when we combine the different modalities. So liver-directed therapy TARE was given, followed by systemic therapy. This led to the excellent response in the scan. So the tumor had shrunk, and also the thrombus had come down, and it had become now bland now. So that is how we get the responses when we combine the different modalities like liver-directed therapy and systemic therapy. So he received 3 more cycles of immunotherapy. Then after that, when we did the scan again, he had excellent response. Even the thrombus had decreased, and also the liver mass had shrunken. So almost he went into a near complete response. So next slide. So again, the tumor markers had come down. The PUCA started with 2000, come to 78, and EFP had also drastically decreased. Next slide. So that's how the rationale of combination of these drugs. What does the liver-directed therapy does is the tear enhances the neoantigen expression on the tumor, and this immunotherapy, when it is given after this the liver-directed therapies, it enhances the tumor immunity and it stops the tumor cell growth. Next slide. So atezobev, again, we know the rationale of combination. Then a bev, what does it do? It inhibits the angiogenesis, stops the blood supply to the tumor. And atezobev, again, that atezo enhances the tumor immunity. That's how these two drug combinations act synergistically in stopping the tumor cell growth. Next slide. To summarize, so in this patient, though the patient was advanced stage BCLCC, because he had a very good liver function, we combined the liver-directed therapy, TARE, along with the immunotherapy, leading to excellent responses. Though this treatment is not suggested by any of the guidelines, but we have to use our clinical judgment and to get that enhanced tumor responses and enhanced survival. And to improve the outcomes, we need to combine the local regional therapy along with the systemic therapy so that we can get excellent outcome. So with this, I end my talk, and I thank you all again. I thank Dr. Anand and Roche for giving me this opportunity. Thank you.
Thank you, Dr. Arif. So we have come to the end of this meeting. Do we have any questions? No. So we can close the meeting. Supporting, please